Thank you, Paul, and hello, everybody, wherever you are tuning in from in the world today. Paul, I'm not so sure about the notorious. That feels like it has some negative connotations, but I suppose I'll take it. Thank you for the kind introduction, and it's great to be talking with you today about one of my most favoured subjects, actually one of the most important things we could talk about, because the threat from carbapenem-resistant Enterobacterialis is perhaps the most significant threat, certainly from an antimicrobial resistance point of view, that we are facing globally currently, and that's likely to be the case for many years to come. So I like to think simplistically, so I've broken this presentation down into three very short chunks. What's the problem? How bad is it? And how do we stop it? So we'll try and spend probably a shorter time on defining the problem by way of introduction, and a little bit more time on understanding what the extent of the issue is we're facing, and thinking about how we can go about preventing it, and maybe reversing some of these trends that we're going to see. So let's start by way of introduction, trying to define this problem. So let me start with my own experience. I joined Imperial College Healthcare NHS Trust in 2015. Now, looking at this chart, you may like to hazard a guess as to exactly when I started. And yes, you guessed it, it was April 2015 was literally my first working day in the trust. And we got hit from my day one with this really significant outbreak of carbapenemase producing Enterobacterialis. It was a Klebsiella NDM. And I learned an awful lot during the course of those subsequent 6 months or so about applied infection control, and we were able to get on top of this dynamic transmission situation. Now, the picture wasn't so straightforward when we began to take into account the molecular epidemiology of the just one strain of Klebsiella pneumoniae. It was at least two, probably three different subclones. And amongst those two different subclones, which were mainly associated with two different hospitals in the group, there were three different mechanisms of colistin resistance that emerged during the outbreak before our very eyes. So the antibiotic of last resort, colistin, we were watching it become ineffective over the course of this short outbreak. And this is in a relatively low antibiotic consumption setting in the UK generally. It's not so bad. If we go to some other parts of the world, as we'll see later, where the antibiotic pressure is even higher, these trends of rapid resistance development are going to be happening even quicker. And I wanted to put this slide in because it's sort of a Manhattan plot. This is plotting the number of inpatients with known CPE. And you'll note that the last point of acquisition was around early January 2025, but it took many months for the patients with CPE to leave our hospital. So even after cross-transmission had been prevented or been stopped, we still saw this colonization pressure and the associated risk associated with that continue way beyond the outbreak ending. So what's the problem? I think we can put it into four different buckets: rapid spread, cost and impact, antimicrobial resistance, and clinical impact on our patients. So let's just delve into those in a little more detail. We were able to spend a bit of time costing this outbreak of 40 patients that had CPE at this trust in London, and we found the cost of the overall cost of the outbreak in excess of £1 million. The big bulk of that cost was driven by elective surgical missed revenue. So we closed our surgical ward for a relatively short period, but because of missed elective revenue, that was the biggest driver. Now that's a good cost, if I can call it that, from a illustrating value point of view, or value of prevention, because that's a really tangible cost to the organisation. money that they otherwise would have had. So whilst it is opportunity cost and not actual revenue, it's as close as you're going to get. The next biggest cost category was staff time, and that's much more debatable in terms of impact, because this was staff time that's already committed. We would have paid for this staff time whether or not we had the outbreak. It's just that the staff time would have been better spent doing other things rather than managing the outbreak. And some of the other costs are relatively minor players. So the financial cost is significant. Antimicrobial resistance cost is also significant. This is an antibiogram a colleague showed me from another hospital many years ago. And look at that, resistant all the way down. Who's seen an antibiogram like that? What do you do when a patient with an antibiogram, with an organism with an antibiogram like that develops an infection? How do we treat them? It's not a straightforward scenario these days. And there's also a significant impact in terms of ultimate patient outcome measured by mortality. And what we can see is that the odds ratio for carbapenem resistant Klebsiella versus carbapenem susceptible Klebsiella is overall around about 2.8. So patients with carbapenem resistant Klebsiella are 2.8 times more likely to die than patients with carbapenem susceptible Klebsiella. That's how stark the difference is. But within this conundrum of antibiotic-resistant gram-negative bacteria, not all multi-drug resistant gram-negative bacteria are created equal. We see very big differences in terms of species when it comes to clinical impact. So something like carbapenem-resistant Acinetobacter is less impactful than an Enterobacterialis species, generally speaking. But this study was interesting because it picked out specifically increased mortality due to metallo-beta-lactamase producing, or MBL producing, Enterobacterialis. So if they had a certain class of carbapenemase, that was associated with a worse outcome in terms of mortality. Now, I think the reason for that is because metallo-beta-lactamase, carbapenemases, tend to be associated with higher levels and broader levels of antibiotic resistance. So they are that much harder to treat. And that's why I think we see this increase in mortality. So we have cost, we have mortality, we also have rapid spread. And that rapid spread is driven by a number of different factors. We have gastrointestinal carriage, which is an important reason why these resistant gram-negative bacteria survive and persist and transmit so well in our hospitals, because they have a really good established ecological niche within the human population of hospitals. They can also spread by clonal expansion. That's where you get a successful clone. Let's say the same Klebsiella and the same NDM spreads from patient to patient. But you can also get horizontal gene transfer, where these bacteria spread and share resistance determinants. That is still an emerging area of science and research. So at this stage, honestly, it's not clear how we intervene to prevent horizontal gene transfer, whereas I think we do have tools to intervene to prevent clonal expansion. So when we start about antibiotic-resistant gram-negative bacteria, it can be a real acronym minefield. So these are just some of the many different terms that you'll hear when we're in the space of multi-drug resistant gram-negative bacteria. And there's a famous story now related to an incident in England where it was the early days of the emergence of CPE in the Manchester region. And so the story goes, one hospital transferred a patient from one Manchester hospital to another, and it was very clear they had a CRC on their medical record. However, the patients at the receiving hospital didn't recognize that as meaning carbapenem-resistant coliform, so they disregarded it. So the lack of standardization and caused an outbreak in the receiving hospital. So the lack of standardization in the terminology and the nomenclature used had real life, day-to-day implications for infection prevention control. So taking a step up, thinking about sort of a higher level view of this issue, we can think about the rising threat of multidrug resistant gram-negative bacteria in the whole. And actually, gram-negative bacteria cause around 2/3 of healthcare-associated infection in the ICU and around 1/3 outside of the ICU. And very broadly, we can classify them as carbapenemase-producing organisms if they produce carbapenemase, and that would include the non-fermenters and the enterobacteriales, or a much tighter group, including only the enterobacteriales, which is your coliform type gram-negative bacteria. And there's differences between the kind of wider CPO group and the CPE group that we won't really go into in detail today. So here's another framework of looking at the distinctions within the enterobacteriales, which I think are quite helpful and important. So at the highest level, we have carbapenem resistant enterobacteriales. So it's either resistant or not, fairly straightforward. But that can be subdivided into CP-CRE, so that's carbapenemase producing CRE, and that would be synonymous with CPE, or NCP-CRE, so that's non-carbapenemase producing CRE. So we know that doesn't produce carbapenemase, it's tested negative. You could probably add a third category, which is query CPE, NCP-CRE. We don't know, we haven't done that test, but that, I thought that overcomplicated a rather complicated slide. So I hope that's helpful. Now, this is a rather simplistic comparison, but I think it's useful in drawing a contrast between CPE, MRSA, VRE, and C. diff. So, for example, with resistance, MRSA, VRE have resistance issues. That's why we're worried about them, but it's one resistance mechanism generally, a single organism. CPE is a much more complicated scenario. We get high levels of resistance, multiple resistance genes across multiple species. And here's a point that's particularly relevant to our thinking today about healthcare and community settings. CPE has the capacity to establish both hospital and community reservoirs. Whilst MRSA can and has established community reservoirs, it's most commonly associated with healthcare provision, and VRE and C. diff are almost exclusively associated in that way. We also see differences in the at-risk patient population, with CPE having the capacity to affect all, virulence, and also the role of the environment too. So, having set the scene and tried to define what the problem is, let's have a think now about how bad it is. Now, this is a new study that I picked up in the preparation of these talks, and it's well worth a read. It's published a year or so ago in Open Forum of Infectious Disease, and it's a really clear and thorough systematic review and meta-analysis of the global prevalence of carbapenem resistance amongst healthcare-associated Klebsiella pneumoniae. Now, the numbers in the forest plot on the right are a little small to see, but perhaps the color coding on the map on the left is a little easier. You can see the red, that's where you have the highest rates of carbapenem resistance amongst invasive Kleb pneumo, rates in excess of 60%. So I think you can see from the forest plot, generally Western Europe is a bit mixed. High income North America has a relatively low rate of carbapenem resistance in invasive Klebs, healthcare associated Klebs. East Asia is mixed, but it's really South Asia that you look at that data and you think universally every study was finding an average proportion over 60%. So more than 6 in 10 of hospital-acquired Klebsiella pneumoniae in South Asia were resistant to carbapenems. That's a really significant finding because that changes the way that we deliver healthcare. If we delve into data from Europe in a little more detail, this is the proportion of invasive Klebsiella pneumoniae isolates resistant to carbapenem, so a slightly different metric, but similar. We see very much a north-south divide in Europe with really, really high rates seen in Greece, in Italy, in Romania, and some other countries in that region. High rates in Spain and Portugal, intermediate rates elsewhere, and the lowest rates up in the Nordic countries, in the northern parts of Europe. But I think perhaps the most compelling data comes from somewhere like Romania or Italy, where the rates of resistance were virtually zero up to around about 10 or 15 years ago, but since then have really skyrocketed. And that's quite salutary, I think, for everybody working in this space, to know that you can have a country where rates were incredibly low, and maybe that you, like me, in the UK, are working in one of those areas where rates are currently very low, but it just shows that over a relatively short period of time, we can see a significant increase in the rate of carbapenem resistance. I think it's good and interesting to dwell on what drives this north-south divide across Europe. We see higher rates of antibiotic resistance in southern European countries than in northern. Why is that? We don't know, but it's interesting to note that other things follow a similar north-south divide pattern. Antibiotic use is a very, very compelling potential causal association with antibiotic resistance, isn't it, in bacteria? But also infection control staffing, single room availability, and national debt also broadly follow the same pattern. So I think it's a combination of factors, but if I had to pick a single factor that is most likely to explain that divide, it's looking like antibiotic use is the smoking gun here. However, a warning: correlation does not necessarily mean causation, because look here, there's a correlation between MRSA-BSL rates in Europe and fair play from the European Football Championships, which are surely not causal, and a correlation between national chocolate consumption and the rate of Nobel Prize winners. Does this really mean that if we eat more chocolate, we've got a bigger chance of a Nobel Prize? I tell you what, let's just assume that is true, and it gives us all an excuse to eat chocolate. But I don't think, sadly, this is a causal relationship. So the point is, whilst many factors are co-correlated with the trends in antibiotic resistance in bacteria across Europe, they're not necessarily causally related. So this is some work I was involved with in London. I think it's quite important, particularly in a low prevalence setting, because of what it suggests is that CPE is out there if only we increase our screening to detect it. So this shows you, this is actually the same organisation. So you can see in April 2015, you might call it the Jon factor. When I joined the trust, the outbreak commenced. It wasn't my fault, really, honestly. And from that point, we enhanced the screening we were doing. And as you see in the later part of this chart, as we increased and ramped up the screening program, the number of new patients we were detecting each month increased. And that suggests to me that the patients were already out there. They were out there for years before. It's just we were not detecting them. So it's a case of seek and you shall find. So bringing us right up to speed, I was part of a review and meta-analysis of prevalence of carbapenem resistance intrabacterialis in healthcare and community settings in the UK. We were limited in this study by the data available, because there isn't really a huge amount of data out there. Not many studies have looked at the prevalence of CPE in healthcare settings, and much less in community settings in the UK. But what we did find overall was, as we expected to find, a relatively low level of low prevalence of both CRE and CPE, both less than 1% overall, with the rates being higher in healthcare and lower in community. Now this chart table suggests that the rate in the community was higher, but that's based on a really small number of studies. So I think the prevalence of CPE at 0.1%, i.e. tenfold lower than in healthcare settings, is a much more realistic picture of current prevalence in the UK. What about prevalence in the community? I found this much harder to answer. There certainly wasn't a nice, neat, systematic review and meta-analysis from a global perspective looking at the prevalence of CPE or CRE in the community. However, there are a number of different studies from various parts of the world that I've summarized here at a very high level. And you can see studies from Southeast Asia with India and Pakistan showing really quite high prevalence of CPE, approaching or in excess of 10% in patients that are either in the community, healthy volunteers, or are being admitted to hospitals. So that's a real concern and a reflection of the issues in hospitals. In studies in Europe, the prevalence is, as we would expect, much lower. And in studies in other parts of the world, one from Africa, one from Vietnam, somewhere in between. So I think the patterns of community colonization with CRE and CPE match what we see in the hospitalized patients with prevalence of CRE amongst Klebsiella that we saw in that first study, the global systematic review and meta-analysis. So I think this is important data, and what it shows and reinforces is that CPE can establish a community reservoir in patients that are otherwise healthy. And that's a real concern when we come to think about what the future looks like in terms of antimicrobial resistance. I'd like to spend the remainder of our time together today having a think about how we can stop the spread of CPE and CRE. And I think the first thing we need to do when we're thinking about prevention is looking at transmission routes. On a very simplistic level, we have a colonized patient, an unexposed patient, and routes in between, which will include hands, which will include surfaces, and we know there's a dynamic interchange between hand and surface contamination. It will also include medical devices. There's a story about duodenoscopes and their role in the transmission of CPE. Sinks and drains is an increasingly important story in terms of the transmission of CRE and CPE. How role does air play in the spread of this organism? Are CPE transmitted through the air? I would say rarely. And finally, do we need to think about staff as a potential reservoir for the spread of CPE? And what do we mean by spread as well? Because we mentioned earlier, we've got the idea of transmission, which is the same bacteria and the same carbapenem, but also this gnarly, challenging issue of horizontal transfer. How do we intervene to prevent that? Is an open question for me. So there's some nice data that's emerged over recent years on the promiscuity of plasmids. There's several clear outbreaks where interspecies plasmid transfer has occurred, and that has resulted in cross-transmission. In one study, I mean, it looked like multiple carbapenems were literally dealt out like a pack of cards from a single index patient. And I think more broadly, there's some nice work showing that on a population level, the picture is consistent with horizontal gene transfer to explain at least a big chunk of transmission events amongst CPE, possibly even the majority. So the message to me is clear that we need to look beyond this same organism, same gene dynamic that we've always followed and think about the possibility of horizontal gene transfer. What would that mean in practice? It would mean our outbreak definition might be any organism producing an NDM on a ward where we've identified a couple of NDMs, rather than saying anybody with Klebsiella pneumoniae producing NDM on that same ward, if you see the distinction there. So this is a nice popular level study that illustrates how horizontal plasmid transfer is a key driver of CPE transmission. So it was a genomic analysis of more than 1,000 isolates submitted to the ref lab. And what they found was that a national intervention aimed at preventing spread worked in that it reduced the transmission of clonal spread, but it made no impact on plasmid-mediated spread. And I think that's what we'd anticipate. And that was borne out by the risk factor analysis. So what they found was the usual kind of risk factors associated with clonal spread of CPE. So direct or indirect wall contact, direct or indirect hospital contact, bacterial species and carbapenemase type are all associated with clonal spread, whereas none of these factors were associated with plasma-mediated spread, which suggests other factors are driving this. We need to think about beyond individual organisms as well. We know that CPE is a mixed bag of different species with very different characteristics. So Klebsiella, for example, is almost 4 times more transmissible than E. coli, according to a big study in the ICU, and it also seems to be more environmental than E. coli, and that could be a factor in why it seems to spread better in hospitals. So let's have a look at our toolbox then to think about what we can do practically to prevent the spread of CPE in our hospitals. We've got contact precautions, screening, stewardship, hand hygiene and disinfection as our sort of core pillars, and some other more peripheral interventions that we may consider important at least some of the time. So let's have a look at screening and isolation. There's lots of discussion, lots of debate, rightly so, about which patients we should screen for CPE. In the UK, we have a framework that suggests anybody in the last 12 months who's been previously positive, been an inpatient in any hospital in the UK or abroad, have multiple treatments, a known link, or admitted to augmented care should be considered for CPE screening. So that's quite a broad set is being recommended now in the UK. How do we screen? I think the collection of the samples is not often talked about, but is a really important part of this story. So I was involved in a study where we were looking at the prevalence of antibiotic-resistant gram-negative bacteria in just over 4,000 patients admitted to a London hospital group. And what we found is that at the start of this study, a high proportion of patients declined to be screened. They just said, no, thank you very much. And it was only after we changed our messaging that we began to see the decline rate reducing to less than 10% in the end. And the modified message was much more patient-focused. It explained why this test was important to the individual and delineated the benefits for the individual and for those close to them, and explained how knowing their colonization status is a helpful piece of information should they go on infection. So, sort of foundationally thinking about what we can do to prevent infection, most infections are preceded by colonization. And in fact, the incidence for CPCRE infection following colonization is around 26%. So 25% of patients who have CPCRE colonization are likely to have an infection at some subsequent point. So that tells us that a focus on patients with known colonization to prevent that transition from colonization to infection will be fruitful prevention work. What about hand hygiene? We know that hand hygiene is really important, and we know that it works to prevent transmission, but we also know that the reality is something like 40% of hand hygiene opportunities are met, which means that 60% are missed, and that's a real problem. So how do we go about improving our compliance with hand hygiene? I think it has to be a hearts and minds piece. We need to remind people at every opportunity how important it is as a foundational intervention. And it's a good horizontal intervention because it won't only help to prevent the spread of CPE, it will also help to prevent the spread of other organisms in our hospitals and protect healthcare workers from their own exposure to these organisms too. What about cleaning and disinfection? A really big emerging theme with these resistant gram-negative bacteria. I think I come back to, again, the work by Susan Huang originally and Brett Mitchell to summarize it nicely in a systematic review, meta-analysis that's been updated recently. And it shows that if a patient is admitted to a room where the previous occupant of the room was infected or colonized with various different organisms, but including resistant gram-negative bacteria, the incoming occupant has an increased risk of acquisition. And that suggests to me quite powerfully that the previous occupant is leaving behind contamination that is then causally linked with the acquisition of the organism in the incoming patient. I mentioned duodenoscopes earlier. This is some information that has been come to light over the past decade, really now. What we know is that the duodenoscope exposure was absolutely associated with acquisition in these cases. There was no breakdown in the procedures. It was just that cleaning these devices to a high level is really, really important. And the FDA have concluded that meticulous cleaning before high-level disinfection reduces the risk of transmission, but it may not entirely eliminate it. And that's something that we've had to get comfortable with, really. Contaminated sinks and drains are a really big emerging theme here. This is a study that's quite powerful, I think, and it shows that the acquisition of Klebsiella pneumoniae clinical infection was halved through improved management of sinks. So for halved for acquisition, even more so for clinical cultures. And it was a big study over a long period of time. And it really suggests that these contaminated sinks and drains are not innocent bystanders of effective practice with washing these bacteria off hands and off other things into the sinks, but rather they get back into the clinical environment and cause issues in terms of patient transmission. What about antimicrobial stewardship then? So older data suggests that the use of carbapenem resistance is probably unsurprisingly associated with subsequent issues with CPE. And equally, sort of at the other end of the scale, if we have better control of antibiotic prescribing, we can see a reversal in antibiotic resistant trends. And in this study, the reversal happened actually quite quickly when certain antibiotics were restricted. Slightly more recently, this is a nice study showing the impact of an antimicrobial stewardship program on both carbapenem consumption and on CPE in Australia. And you can see that both carbapenem use and CPE detection trended downwards, associated temporarily with the introduction of this stewardship campaign. So those are sort of our pillar interventions, but what are the sort of more peripheral interventions? We'll just take a moment to think about a few. One is de-isolation. Is it ever safe to say a patient is no longer considered colonized? Well, certainly not quickly. The mean and median duration of colonization, certainly for inpatients, is long. So I think during an individual inpatient stay, we have to consider a patient with CPE to be colonized throughout the stay, regardless of what subsequent screens may say. If they're discharged to the community and readmitted, or how do we manage them in the community, or outside of an acute hospital at least, I think there may be some scenarios there where we could look at de-isolation through careful serial screening. Is decolonization going to be possible? Selective digestive decontamination, which is the administration of systemic antibiotics, didn't actually make much difference in terms of colonization. There was an initial impact over the first couple of weeks, but then the levels of colonization returned back to normal. And given the potential and quite tangible unintended consequences of selective digestive decontamination using antibiotics, this isn't a recommended strategy. Put another way, antibiotics like A-bombs, they absolutely obliterate the microbial flora, and that causes subsequent issues for patients. What about decolonization using fecal transplant? I was really excited to see this study come through a couple of years ago now, but actually the results were fairly disappointing. A standard control group or an intervention group, there wasn't a great deal of difference, unfortunately, between the kind of carriage rates at the various time points in the study. So that was a bit of a disappointment. Clostine is an interesting one. We're not going to decolonize the skin of a patient with colonization with CPE because the primary reservoir is in the gut, and I think the skin contamination probably comes from the gut contamination. But we know we can reduce the burden of bacteria on the skin, and that can be helpful in two ways. One is that it reduces the risk of colonization proceeding into infection, but it also reduces the risk of cross-transmission in our hospitals. And finally, in terms of the sort of out-of-the-box interventions, do we look at colonized staff? Well, to Pandora, do not open the box. staff screening can be seen as a bit of a Pandora's box, in that once it's opened, where do we stop? Do we start doing it routinely? Do we start doing it for all organisms? This was some work done not so long ago, and it showed actually a very, very low level of colonisation with staff that was no different to colonisation of control participants working in a hospital. And that was quite reassuring. It may not be the case all the time, and I think it's something we need to keep an open brief on. So I hope that's been a useful discussion for you today. I'm open to questions. Feel free to drop me a line on my email address there. We've taken a quick look at what the problem is with CPE, thinking about those consequences in terms of the transmission, the rapid spread, the cost, and the impact on our patients, and the impact on antimicrobial resistance as a whole. We thought about how bad is it, and actually the answer is unfortunately quite bad. We're seeing really quite high levels of carbapenem resistance in many parts of the world, and that is now driving changes in our therapeutic approach and our preventative approach as well. And we've looked at how we can intervene to prevent transmission. We don't have all the answers, but we do certainly have some evidence that these kind of core interventions are effective in reducing cross-transmission around screening and isolation, around hand hygiene, around environmental hygiene, and antimicrobial stewardship. So with that, I'll conclude and say thank you for listening today.